This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. Okay, this is going to be narrow complex tachycardia, and this is going to be AHA 2010. We're going to go over pathology of the SVTs, or narrow complex tachycardias. We're going to go over a pharmacology review, initial treatment, and then a quick scenario. So, an SVT does not have any discernible P wave. So whenever we're looking at this, this is sinus tachycardia. The reason it is because we can make out a P wave that is initiating this QRS. So that means that your actual beat is coming from the sinoatrial node. Now, in an SVT, we have an alternate pathway, or some place that's completely different, or multiple pathways that are giving us aberrant beats. Now, the problem with this is that the entire atria runs at 60 to 100 beats per minute. So if you have 3 ectopic sites generating stimulus to the SA node, or I'm sorry, to the AV node, 3 times 60, very quickly you can get up there in very high rates. A heart rate of 180, 200 beats per minute. The more ectopic sites that you have, the faster the heart rate will actually be. This is an SVT here because it's sustained, it's continuous. If we saw it come or go, then we would consider that a PSVT. But since this is sustained and the only thing that we can see is the SVT, we're going to consider this is a sustained SVT, and we'll treat it as such. There is no P wave or no discernible P wave in this rhythm whatsoever. Now if we'll look up here, this come from about the area of the SA node, but didn't come from the SA node. So we're still going to have about the same intrinsic rate. The SA node will be firing as well. So if both of them are running at 100 beats per minute, then the rate on this is going to be near 200. What we see here is a rate that's near 270 beats per minute. You can do this by counting all the QRSs in the 6-second strip and multiplying by 10, or by doing the R to R method, 300, 150. This rate is greater than 150 but less than 300. And this is an SVT because it has no discernible P wave. A flutter, if you'll count these up with me really quick, there's one that's pretty close. These are about 300 beats per minute too. So if the AV node was responding to every one of these flutter waves or these F waves, then the rate could be in excess or near 300 beats per minute. Atrial fibrillation, again we have F waves, but the F waves are fibrillation waves, and the higher the amplitude on these fibrillation waves, the greater chance it is that the AV node will take up that beat and run with it. Now, fibrillation is essentially the entire atria up here quivering or fibrillating. Now, what will probably occur is this will be irregularly irregular, and that's how we identify an AFib. We can't tell what one R to R interval will be and what the next one will be. Now, treatment. Let's talk about that. Let's go back here a little bit. Treatment of a sinus tachycardia. Well, the answer is to figure out what put them into a sinus tachycardia. Examples of this is going to be hypovolemia, another example of this would be a PE. If a person has an occlusion into their pulmonary trunk, their heart's going to just respond to the stimulus it's getting, and the stimulus it's getting is that I'm hypoxic. This is an SVT, probably adenosine. We're going to essentially restart this section. And in A-flutter or A-fib, the ideal drug of choice is probably going to be a calcium channel blocker. And that's because calcium channels is what initiates the action potential on the other side. Now, at the AV node level, what we get is a calcium release. And whenever the calcium is released, it initiates the action potential. So I can't, if I have A-flutter or A-fib, I can't control the atria anymore, but I can sure retard or slow down the AV node. The easiest way to do that is with a calcium channel blocker. Atrial fibrillation in the acute setting, the best way to control F-wave input to the AV node is with a calcium channel blocker. These are the medications that they'll primarily use. We're going to talk about in this section beta blockers, calcium channel blockers, and then other medications. First one we're going to talk about is beta blockers, Lopressor. In the event of an MI, Lopressor might be the easiest one. This is a selective beta-1 agonist, which means it pretty much works on rate and contractile force strength. And the primary indication in this is atrial tachycardias with ectopy. The adult dose is 5 milligrams every 15 minutes times 3, and then 50 milligrams PO to target dose. Maximum is going to be 200 milligrams daily. Absolute contraindications in this is going to be bradycardia, heart failure of any sort, and then cardiogenic shock or congestive heart failure, which would be a type of heart failure. Diltiazem or Verapamil, both of them are calcium channel blockers. The number one calcium channel blocker of choice, or the one with the highest efficacy, is going to be Diltiazem or Diltiazem. It blocks the calcium channels. Again, this is for a rate or a rhythm that is irregularly irregular. And this would be one that is actually run from the AV node. So you have either flutter waves or you have fibrillation waves that are all hitting the AV node. You can't control the upper atria anymore, but you sure can control the AV node. The easiest way to do that is with a calcium channel blocker. This also does not make your patient as hypotensive as, say, Verapamil would, but it can make your patient hypotensive. Primary indications on this are going to be SVTs with AFib, supraventricular tachycardias with AFib, A-flutter, and or hypertension. We can also use Diltiazem and Cardiazem for. Not only does it work on the calcium channels of the AV node, it also works on the calcium channels of the tunica media of the vessels, and it helps us dilate those out. Adult dose is going to be 0.20 to 0.30 milligrams per kilogram. We're going to cap that, though, at a maximum of 20 milligrams in one setting. Some books, it'll even take this up to 0.35. The rest of it, after this, let's say we had a 100 kilogram patient, and we wanted to start them off at 0.20, where that would be 20 milligrams that we would need to give them. We could still give up to, depending on which books you're looking at, 15 more milligrams. This would be given to them in the next 10 minutes after our initial bolus to finish this off. But in one setting, we only give 20 milligrams maximum. Absolute contraindications on this medication are going to be high degree heart blocks. So if there's a physical block there, we do not want to put on board any type of chemical block, and or if the patient is hypotensive. So if the patient initially had a blood pressure of 70/30, this would not be the medication of choice. This is an older calcium channel blocker, Kalan Isoptin or Verapamil. Mechanism of action on this is going to be a calcium channel blocker, and its primary indications was for AFib and A-flutter. Adult dose in this is going to be 5 milligrams, a very slow IV push, 10 milligrams, and then 10 milligrams. The problem with Verapamil was that it would make your patient hypotensive. Absolute contraindication for this is going to be AV blocks. Physical block is present. Please don't put on board a chemical block. And congestive heart failure. So an example of this is if you had a patient with an irregular beat and you was wanting to use Verapamil to stop that, and they weren't an SVT, and the patient's blood pressure was stable, 120/70, by the time that you got finished giving the Verapamil, the patient's blood pressure would not be stable. It would be below 100, 70/30, hypotension, diaphoretic. So this medicine here had a nasty habit about opening up the tunica media of the vessels. The last two meds on our list are going to be adenosine and amiodarone. Adenocard is the ideal drug of choice for any kind of neurocomplex SVT. The reason is it slows conduction through the AV node. If any of you have ever used this before, it creates us a little bit of a systole. The nice thing about this is, let's just go down the list here. Primary indications are going to be SVT and Wolff-Parkinson's-White. And the pharmacokinetics is this stuff onsets as soon as it hits the heart. The duration on this is less than 30 seconds. Now, the cool thing about that is that you can almost use this drug diagnostically. It's metabolized in the liver. The adult dose, AHA standards, are going to be 6, 12, and 12. And since the half-life is so short, we do a rapid IV push. It is even better if we can load both of the needles into the same hub, or set up an extension set to where we can give the medication and give the flush right behind it. Absolute contraindications on this are going to be if the patient is allergic, or any type of high degree heart block, or AFib or VTAC. Now the reason we have an absolute contraindication on AFib and VTAC is because we've just wasted the patient's time. It will not probably work on AFib, and it will not work at all on ventricular tachycardia. Last but not least, Cortisone or Amiodarone. This is our multi-spectrum antidysrhythmic. It does a little bit of everything. So if there's any question, it appears wide. It is close to being wide. We've tried adenosine, and we still have a stable patient wishing to call for some amiodarone. Amiodarone is a multi-use antidysrhythmic. It increases parasympathetic tone, holds a von Williams classification of a class 3, which is a potassium channel blocker, and has a calcium channel blocker in it. This may make your patient hypotensive though. Primary indications for this are going to be VTAC, VFib, AFib, or any type of SVT. Multi-use antidysrhythmic. Here's the bad thing about amiodarone. It sticks around like luggage. The half-life on it is 26 to 107 days, depending on how well your liver's working. The adult dose of amiodarone is going to be 150 milligrams over 10 minutes. And we're going to do this times 3. So again, the total dose is going to be 450 milligrams. But this will be given over 30 minutes if we continuously give this. Absolute contraindications is any type of high degree heart blocks, second or third degree blocks, pump failure, and or bradycardia. Drug interactions, it does not like other antidysrhythmics. Beta calcium channel blockers are some examples of these. If the patient is already taking them and they're on the sustained release version, be aware that you might get more bang for your buck out of the amiodarone. Amiodarone, in addition to that, has some pro-arrhythmic contraindications with certain antidysrhythmics, procainamide being one of those. So if you're mixing amiodarone and procainamide together, you will create this on the monitor. Let's talk about, this is the treatment algorithm from the American Heart Association. So assess appropriateness for clinical condition, and the heart rate typically is greater than 150 beats per minute. So they have to be 150 beats per minute. The next thing is if we can identify the underlying cause, that's what we need to do. Be sure that their airway is patent, that they have enough oxygen, that we have a cardiac monitor and blood pressure, and kind of taking a look at everything. And, pardon me, persistent tachydysrhythmia, and if any of these symptoms are present, your patient may be unstable. More specifically, if this one is present, your patient is unstable. If your patient's blood pressure is below 100 millimeters of mercury, systolic, your patient is unstable. If that is the case, you're going to go immediately to synchronized cardioversion. The synchronized cardioversion settings for narrow, regular, and irregular start off at 100 and work their way up to 360. If the patient is not unstable, and that means they have a normal blood pressure, they're not hypotensive, don't have an altered mental status, signs and symptoms of shock, chest pain and discomfort, or acute heart failure, then what we're going to do is we're going to ask one more question. The other question is does the patient have a wide QRS? If they do not, and we're still thinking that it's a narrow QRS, the treatment is as followed down here. We're going to establish an IV, get a 12 lead if available. We're going to take a picture of 12 witnesses to this and take a better look at the heart. Attempt some vagal maneuvers if possible. Vagal maneuvers are performed by having the patient bear down or increasing vagal response. They're also performed by blowing on a closed syringe. This would be a stretch reflex in the actual lung tissue. We can dunk their head or place cold water on their head. This is caused from a mammalian diving reflex, and this will also increase vagal tone. Bruise and carotid massage is not suggested. If a person has a plaque built up in their tunica media, you may break it free. Beta blockers and calcium channel blockers are secondary medications for neurocomplex, and then always consider a cardiologist or expert consultation. Your scenario is as followed. A 45-year-old male with onset of lightheadedness and chest pressure times 1 hour ago. Patient found sitting at home. Skin is moist to touch. He's alert and oriented times 3. Person, place, and time. Vital signs are blood pressure 150 over 100, pulse 150, and respirations are 24. You hook him up to the monitor and it shows this.
Perform a primary assessment, airway, breathing, circulation, and vital signs. Obtain a sample OPQRST history. Start an IV on the patient. Start treatment. Vagal maneuvers first. Adenosine, 6, 12, and 12 milligrams rapid IV push, considering Diltiazem and considering synchronized cardioversion. Transport the patient to the closest appropriate facility.
Scenario 2. 72-year-old male with previous history of SVT. Patient currently taking digoxin, 0.125 milligrams daily. Patient with chest pain, 4 on a 10 scale, and short of breath, speaking 4 to 5 word sentences. Vital signs, blood pressure 98 over 50, pulse 160, respirations 22. Patient found in kitchen, sitting in the chair.
Perform a primary assessment over the airway, breathing, and circulation and obtain a set of vital signs. Obtain a sample OPQRST history. Pre-medicate, however, do not delay cardioversion. Synchronize cardioversion at 100, 200, 300, and then 360. Transport to the nearest appropriate facility.